Hey, it's Dr. Bill with just the tip of urology school. Today we're going to discuss MRI, a great diagnostic tool in urology. Fluid in the collecting system is very bright on T2 weighted imagery, and that allows us to look at a various number or variety of urologic issues. After ultrasound, the MRI is the modality of choice for patients with iodine contrast allergies, mild renal insufficiency, and pregnancy. It is, however, very poor in detecting stone disease. Gadolinium-based contrast should be avoided during pregnancy and lactation. Nephrotoxicity does occur in stage 4 and 5 chronic kidney disease. There's something called nephrogenic systemic fibrosis that can occur from the MRI contrast when renal insufficiency is significant. And that's basically fibrotic disease of the skin and a variety of organs. This can be avoided with minimal dosing and, in some patients, hemodialysis after an MRI. Clinical applications, it's great for adrenal pathology. However, a CT-weighted study is thought of as the gold standard. Pheochromocytomas can demonstrate a very specific bright signal intensity on T2 weighted imaging called a light bulb sign. MRI is the gold standard for tumor thrombus in renal cell carcinoma and is very specific in renal cell carcinoma for bony metastatic diseases. To get an idea of the MRI features of renal masses, go to the AUA core curriculum. Urothelial tumors are easily identified in MRI studies. We can look for renal function assessment as well. Bladder cancer in staging and identification of wall penetration or muscle penetration and intravesical extension, as well as extravesical extension and lymph node disease. It's a great modality for this as well. We're seeing a lot of use of MRIs, diffusion weighted for prostate cancer, looking at PRADS scoring, level of 1 through 5. The higher the number, the more suggestive of significant prostate cancer is. It is great for staging for patients with high risk prostate cancer. It's great for patients with previous negative biopsies, for pre-surgical planning of radical prostatectomy, and for active surveillance. A lot of times we have protocols that instead of doing routine biopsies, we can supplement with MRI visualization and utilizing MRI-directed prostate biopsies. It's also great for assessing local recurrence of prostate cancer after a prostatectomy. So a lot of nuances in utilizing and ordering an MRI in your urologic practice. As always, use the guidelines on the AUA. There's some very interesting and informative tables and classifications for use of the MRI in your core curriculum. Dr. Bill with just the tip of urology school in utilizing MRI for another diagnostic tool.